Welcome to today's deep dive. Our mission today is to unpack this really critical but honestly often overlooked reality, which is the intersection of pregnancy and stroke risk.
Yeah, it's a topic that definitely doesn't get enough attention.
Right. And, we're pulling our insights today from a really comprehensive June 2026 paper. It was published in the neurology journal Continuum, authored by Dr. Michelle H. Leppert. And I think, well, we usually think of pregnancy through this very soft, glowing lens, right? Like
Uh,
baby showers, tiny shoes, painting the nursery.
Exactly, the sentimental side of it.
Yeah, but if you strip away that sentimentality for a second, you are looking at a massive, frankly, kind of violent cardiovascular overhaul happening inside the body.
Oh, absolutely. I mean, it is a profound structural and chemical transformation. Functionally, a pregnant person's physiology alters in these really extreme ways just to sustain new life. And, paradoxically, those exact survival mechanisms put them in very real danger.
Hey, how much danger are we talking about here?
Well, stroke complicates about 30 out of every 100,000 pregnancies in the U.S.
Hmm.
Yeah, it makes it a leading cause of maternal mortality. So to understand why that happens, you really have to stop viewing pregnancy solely as this reproductive event and see it for what it actually is, which is a radical vascular adaptation.
Okay, so let's look under the hood at those mechanics.
Mm.
The paper points directly to something called Virchow's triad. And I've heard the term thrown around in medical context, usually regarding like deep vein thrombosis in people who take really long flights. But how does that apply to a pregnant patient?
Right, so Virchow's triad basically outlines the three fundamental physiological conditions that promote blood clot formation. So first, you have hypercoagulability, meaning the blood is, well, unusually thick and prone to clotting.
Okay.
Second, you have venous stasis, where the blood flow becomes really sluggish. And then finally, vascular injury, which is just physical damage to the blood vessels themselves. And a normal, healthy pregnancy essentially forces the body to hit all three of these risk factors simultaneously.
I mean, the hypercoagulability part makes a dark kind of evolutionary sense, right? Like the body is preparing for the trauma of childbirth by, I don't know, stockpiling sandbags before a flood.
That's a really good way to put it.
It knows delivery involves this massive risk of hemorrhage, so it aggressively thickens the blood so the mother doesn't bleed out. But I mean, that same preparation has to be causing a massive traffic jam in the veins.
Yeah, exactly. The liver actually shifts its manufacturing priorities entirely. It starts pumping out much higher levels of pro-clotting proteins, things like fibrinogen and von Willebrand factor, while actively decreasing the production of natural anticoagulants.
So it's just chemically primed to clot.
Completely. The blood is chemically primed to solidify the second it detects a leak. But like you said, that thick, clot-ready blood is now circulating through a system that is experiencing the second part of the triad, which is venous stasis.
Now, is that sluggish flow just a result of having more blood volume overall? Because I know a pregnant person's blood volume increases by something like 50%. It seems like the pipes would just be overcapacity.
The volume increase definitely plays a role, but the stasis is primarily mechanical. I mean, as the uterus expands, it physically compresses the major blood vessels in the abdomen, specifically the inferior vena cava and the iliac veins.
Oh, literally squishing the veins.
Right. It creates a literal roadblock for venous return from the lower body back up to the heart. And the compression is asymmetrical, too. It's far more pronounced on the left side, just due to the specific routing of human anatomy.
Wait, so if a pregnant woman develops a deep vein thrombosis in her leg, the odds are heavily skewed toward the left leg just because of the anatomical real estate?
Exactly. The anatomy dictates the risk there. And then you combine that physical crushing of the veins with a massive influx of progesterone.
What does the progesterone do?
So progesterone acts as a systemic, smooth muscle relaxant. It
Wow.
relaxes the walls of the veins so they can stretch and accommodate that extra 50% blood volume. But, when you relax a vein, it loses its tone.
It gets floppy.
Yeah, it turns from a firm muscular hose into a floppy balloon, and the blood just pools down on the lower limbs.
Okay, so we have thick blood, pooling and relaxed, physically compressed veins. The final piece of the triad is vascular injury. I'm guessing the delivery itself provides that.
You got it. Delivery, whether it's vaginal or cesarean, involves significant endothelial trauma, especially down in the pelvic region. The sudden physical injury to the blood vessels acts as the spark.
Letting the powder keg.
Right. It kicks that hyperactive coagulation cascade into overdrive right where all that blood has been pooling for months.
Wow. So if the body is physically trapping all this thick blood in the legs for 9 months, my immediate fear is the trauma of the delivery room. I mean, the baby gets heavier, the vessels get more compressed, the blood gets thicker. The moment of birth must be the absolute peak of the danger zone for a stroke, right?
See, that is the logical assumption. But the data tells a deeply counterintuitive story. The highest risk of stroke isn't actually during the bulk of the 9 months of pregnancy.
Really? Then when is it?
The risk dramatically spikes during the peripartum and postpartum periods, so specifically starting just 2 days before delivery, but extending all the way up to 6 weeks after the baby's born.
6 weeks postpartum. Wow, I'm trying to square that with blood pressure because, well, high blood pressure is one of the primary drivers of stroke. If the stroke risk peaks after delivery, does blood pressure peak then too?
Yes, and that surprises a lot of people.
Because I always assumed a pregnant person's blood pressure just slowly climbs higher and higher as the physiological strain increases over the 3 trimesters.
Nope, the blood pressure curve is actually U-shaped. During the first half of pregnancy, that massive wave of progesterone causes systemic vasodilation. The blood vessels widen so much to accommodate the new blood volume that blood pressure actually drops.
Wait, it drops?
Yeah, it typically hits its absolute lowest point around 20 weeks of gestation. In many women, it's significantly lower than their pre-pregnancy baseline.
Okay, so they get a dip in the middle. But the rebound must be intense if the stroke risk is peaking postpartum.
Oh, the rebound is where the danger lies. According to Dr. Leppert's paper, blood pressure sharply rises after birth, peaking 3 to 5 days after delivery.
3 to 5 days. Why then?
Think about the mechanics. During pregnancy, a massive amount of fluid leaks out into the surrounding tissues, which is, why pregnant women experience so much swelling in their legs and feet.
Right, the classic swollen ankles.
Exactly. After delivery, all that extra fluid gets rapidly reabsorbed from the tissues back into the vascular system. At the exact same time, the blood vessels are regaining their tone and clamping back down. So you have a sudden surge of fluid volume trying to squeeze through newly narrowed pipes.
Wow, 3 to 5 days after delivery, the pressure spikes? But I mean, in the U.S., standard hospital discharge after a routine delivery is often within 48 hours. So
Yeah.
by the time that blood pressure hits its absolute maximum danger zone, that mother is likely just sitting on her couch at home, completely unmonitored.
That is the terrifying part. They are outside the heavily monitored hospital environment precisely when their cardiovascular system is experiencing its most volatile rebound. This is exactly why postpartum monitoring is absolutely critical, and tragically why a large portion of maternal strokes happen when the patient is just dealing with a newborn at home.
And if you're at home, I mean, the timeline of risk extends weeks past delivery. The most common warning sign people mention for stroke is a sudden headache. But trying to parse a headache when you have a newborn feels impossible.
Incredibly difficult.
Right. You're profoundly sleep deprived, dehydrated, your hormones are crashing. It's like a check engine light that you might just assume means you're low on sleep. It's like trying to listen for a failing bearing in your car's engine while driving through a hailstorm. Everything hurts. How do patients or doctors isolate a lethal neurological symptom from the standard baseline of postpartum exhaustion?
It is genuinely one of the hardest distinctions to make in clinical practice. But Dr. Leppert highlights a staggering statistic in her paper. Over 1/3 of all neurology consults for headaches in pregnant and postpartum women end up being diagnosed as secondary serious causes.
1/3. You mean 33% of the time a neurologist is called in for a pregnant or postpartum patient with a severe headache, it's an actual dangerous pathology, not just sleep deprivation.
Yes, 32%. We're talking about conditions like hypertensive disorders of pregnancy, or HDP, primarily preeclampsia. Preeclampsia is the leading cause of strokes during this window. And we also see things like reversible cerebral vasoconstriction syndrome, or RCVS.
Okay, I need to stop you there. Reversible cerebral vasoconstriction syndrome. Break down those mechanics for me. What is actually happening in the brain?
So in RCVS, the smooth muscle in the walls of the blood vessels inside the brain becomes highly reactive and suddenly spasms.
Just out of nowhere.
Pretty much. The vessels narrow dramatically, restricting blood flow. And this causes an excruciating, sudden onset thunderclap headache.
Oh, wow.
And because the vessels are spasming and the pressure dynamics in the brain are fluctuating so wildly, it can easily lead to either an ischemic stroke from a lack of blood flow or a hemorrhagic stroke if a weakened vessel actually ruptures under the fluctuating pressure.
That sounds terrifying. And preeclampsia is even more common, right? Are there pre-existing vulnerabilities that act as a precursor for these conditions? Because clearly not everyone who gives birth develops preeclampsia or RCVS.
Right. And one of the most critical vulnerabilities the paper identifies is a history of migraines.
Really?
Mm.
Migraine.
Yes. Migraines are highly prevalent in women of reproductive age, affecting up to 25%. And epidemiologic studies show that women with a history of migraines face up to a 17-fold high risk of stroke during pregnancy.
A 17-fold jump just for having migraines. That implies the migraine isn't just a symptom, but an indicator of some, like, underlying structural issue.
You're exactly right. It appears to be mediated by endothelial dysfunction. The endothelium is the delicate inner lining of the blood vessels. In migraine sufferers, there is evidence that this lining doesn't regulate vascular tone as efficiently as it should.
So it's already a little compromised?
Right. Women with migraines have a significantly higher risk of developing preeclampsia. The odds ratios can be 3.5 times higher. The underlying vascular quirks that cause migraines seem to prime the body for the severe systemic vascular failure of preeclampsia.
So they really can't ignore it.
Definitely not. If a patient has a history of migraines, they need aggressive blood pressure monitoring, and they absolutely cannot simply brush off a severe postpartum headache as their, quote, usual migraine.
Okay, let's follow the darkest timeline here. Say a postpartum patient with a migraine history gets that thunderclap headache. They get to the emergency room, and they're actively having a stroke. This is where I start to see a massive conflict.
How so?
Well, I've always been told that pregnant women cannot be exposed to radiation or heavy medications. The fear of harming the fetus is drilled into everyone, right? I assume the medical team is severely limited in what they can actually do.
The hesitation to treat pregnant patients is incredibly common, but honestly, it is deeply misguided. Dr. Leppard's article stresses that most fatal maternal strokes are preventable with earlier recognition and proactive management.
Preventable.
Yes. The fear of fetal harm often paralyzes the care team, leading to delayed diagnosis. We really have to dismantle the myth that you can't scan these patients.
Okay, well, let's lay out the actual rules of engagement then. When a pregnant patient comes in with stroke symptoms, what imaging is actually on the table?
The paper includes a very detailed radiation safety table. The first thing you need to see if a stroke is actively bleeding is a non-contrast CT scan of the head. That exposes the fetus to 0.001 to 0.01 milligrams of radiation.
Oh, it's the danger level.
Well, to put that in perspective, the threshold for fetal harm is generally considered to be around 50 milligrams.
Oh, so the CT scan is thousands of times below the danger throreshold.
Exactly. It's
Yeah.
totally fine. MRIs without contrast are completely safe too, involving zero ionizing radiation.
Ah.
Even an endovascular thrombectomy, where a surgeon threads a catheter into the brain to physically pull the clot out under fluoroscopic guidance, exposes the fetus to a maximum of 0.06 milligrams.
So even the surgery is safe.
It is highly viable and should absolutely be performed if the mother's neurological status requires it.
Okay, so the physical imaging and mechanical retrieval are safe. But what about chemical interventions? Can doctors administer Morphy blood thinners, thrombolytics to, bust the clot?
They can, but the physiology of preeclampsia demands extreme precision from the medical team here. If the stroke is happening in a patient whose pregnancy is complicated by a hypertensive disorder like preeclampsia, doctors must pause and check a complete blood cell count before administering any clot buster.
Wait, why specifically preeclampsia? What is the preeclampsia doing to the blood that makes a blood thinner dangerous?
Well, remember we talked about endothelial dysfunction.
Yeah, the inner lining of the blood vessels.
Right. Preeclampsia severely damages that endothelial lining system-wide. Think of the inner wall of the blood vessel turning from a smooth, Teflon-like surface into a jagged, scraped-up pipe. The body responds to this damage by sending platelets, microscopic clotting cells, to patch up the microscopic scrapes everywhere.
Oh, I see. So the body is consuming its own supply of platelets just to hold the damaged vessels together.
It does this so aggressively that the overall platelet count in the bloodstream just plummets. It's a condition called thrombocytopenia.
And if they have that?
If you administer a powerful chemical blood thinner to a patient whose platelets are already critically depleted by preeclampsia, you strip away their last remaining defense. You could easily trigger a catastrophic fatal hemorrhage elsewhere in the body. You have to check the platelets first. If the count is safe, you treat the stroke.
Man. Okay, so say the acute crisis is managed. The doctors scan safely, they check the platelets, they bust the clot, the mother and baby survive. You'd hope the medical chart just gets closed and they move on, right? But the paper doesn't stop at the postpartum phase. It pushes into this idea that the 9 months of pregnancy leave an imprint that lasts for decades.
Yeah, we are moving past the archaic idea that pregnancy complications are just isolated events that magically resolve the moment the postpartum period ends. The modern neurologic and cardiovascular fields view pregnancy as the ultimate physiological stress test.
Like putting a patient on a treadmill to see if their heart throws an irregular rhythm, except this treadmill runs 247 for 9 months while building an entirely new organ system.
That's a perfect analogy.
Right, and if the body's vascular infrastructure starts to buckle under that sustained pressure, like if the blood pressure skyrockets or the blood sugar processing fails, it's revealing cracks in the foundation that might not otherwise show up for another 30 years.
Exactly. The paper outlines several adverse pregnancy outcomes that act as a direct predictor for a woman's future cardiovascular health. Preterm birth, gestational diabetes, placental abruption, and preeclampsia are massive red flags.
Just how massive are we talking?
The numbers are undeniable. If a woman experiences a preterm birth, meaning delivering before 37 weeks, her relative risk of having a stroke later in life increases by 65%.
65%. That's not a marginal increase. That's huge.
It really is. If she has gestational diabetes, her stroke risk increases by 45%. And if she develops preeclampsia, her risk of a hemorrhagic stroke later in life is nearly 3 times higher than a woman who had an uncomplicated pregnancy.
The implications of that for routine medical care are just wild to me. Think about it. If a 60-year-old woman walks into a primary care clinic to assess her stroke risk, her pregnancy is 30 years in the rearview mirror. A doctor usually asks about smoking, cholesterol, maybe family history. They aren't asking about what happened in the delivery room in 1996.
But they absolutely should be. Dr. Leppert is advocating for a massive paradigm shift here. Neurologists and primary care doctors must routinely take a detailed obstetric history for all female patients. Preventative neurology for a 60-year-old woman has to include a deep dive into her childbearing years.
Because that was the ultimate test.
Right. If she failed that stress test at 30 with gestational hypertension or preeclampsia, she needs to be managed much more aggressively in her 40s, 50s, and 60s regarding blood pressure targets and cholesterol management.
So let's pull this all together for everyone listening. We started by exploring Virchow's triad, how the body chemically thickens the blood for survival, while the growing uterus mechanically traps that blood, creating a massive clotting risk. We unpacked the counterintuitive timeline, revealing that the rapid fluid shifts after birth make the days immediately following delivery the most dangerous window.
Which is when they're usually at home.
Exactly. And we learned that modern stroke treatments and scans are overwhelmingly safe for pregnant patients, provided doctors understand the mechanics of conditions like preeclampsia destroying the body's platelet supply. And finally, we saw how a complicated pregnancy acts as a crystal ball, forecasting stroke risk decades into the future. Thank you for joining us to unpack this vital material.
If we want to push this concept of the cardiovascular stress test one step further, there's a fascinating concept that builds on this underlying biology. If the way a body handles pregnancy unmasks a mother's future stroke risk, could the placenta itself hold the ultimate genetic and vascular blueprint of her future brain health? Imagine a scenario where simply analyzing the discarded placenta after birth unlocks a highly personalized, lifelong preventative care plan for the mother.
Wow. Looking at pregnancy not just as bringing new life into the world, but as an intricate cardiovascular overhaul that generates a map to save the mother's life 30 years down the line, it completely reframes the entire experience. Something to really think about the next time you hear someone's expecting. See you on the next deep dive.